Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for November 2010. They include an update on public perceptions of mental illness and research on the neural circuitry of postpartum depression, the genetics of autism, and psychotherapy for older adults with major depression and executive dysfunction. The article on psychotherapy has been selected as meriting CME for readers who subscribe to the AJP CME course program. Each month, brief companion exams are created for 3 of the most influential articles from the issue. By reading the articles and completing the online exam, individuals can earn up to 1 AMA PRA Category 1 credit per article. This activity is sponsored by the American Psychiatric Association. To subscribe, click on the CME link at our homepage, ajp.psychiatryonline.org. And don't forget to check out the full November issue. Our clinical case conference is about an identity crisis involving body image in a young man with autism. And our review article presents new insights into the biology of depression. We'll start with a report by Bernice Pescosolido on current public reactions to schizophrenia, depression, and alcohol dependence. Recent efforts have tried to increase scientific understanding of mental illness among the public with the goal of reducing stigma. The data for the study came from the General Social Survey, which covers a nationally representative sample. Change was measured by comparing results from 2 surveys conducted 10 years apart, in 1996 and 2006. 3 broad areas were examined: neurobiological understanding of mental illness, treatment endorsement for a variety of providers, and acceptance or rejection of persons with schizophrenia, major depression, or alcohol dependence. The survey used vignettes to present case descriptions that met the DSM-IV diagnostic criteria for the 3 diagnoses. Nearly 2,000 respondents were randomly assigned to each vignette. The respondents were asked how likely it was that the person in the vignette was experiencing a mental illness or the normal ups and downs of life. They were also asked how likely it was that the situation was caused by a genetic or inherited problem, a chemical imbalance in the brain, bad character, and the way the person was raised. The questions were not mutually exclusive, and a measure was coded 1 if the respondent labeled the problem as mental illness and attributed the cause to either a chemical imbalance or a genetic problem. It was coded 0 otherwise. The respondents were asked whether a person in the vignette should consult a general medical doctor, see a psychiatrist, enter a mental hospital, and take prescription medications. Stigma was divided into social distance and the perception of dangerousness. The questions about social contact asked about willingness to associate with the hypothetical person in various ways: to work closely with them on a job, to live next door, to spend an evening socializing, to marry into the family, and to be a friend. Responses of definitely unwilling and probably unwilling were classified as stigmatizing. The questions about dangerousness were how likely is it that the person in the vignette would do something violent toward other people, and how likely is it that the person would do something violent toward himself or herself. More of the public embraced a neurobiological understanding of mental illness in 2006 than in 1996. A large and statistically significant increase was evident across nearly all indicators and all vignette conditions. For schizophrenia, the percentage rose from 76 to 86. The increases were similar for depression and alcohol dependence, but fewer than half of the respondents attributed alcohol dependence to biological causes in 2006. Social or moral conceptions of mental illness decreased across most indicators, but for alcohol dependence, they were either unchanged or actually rose. The attribution of bad character significantly increased from 49 to 65%. Public endorsement of medical treatment rose across the board, as did endorsement of prescription medication. No significant decrease was found in any indicator of stigma. A majority of the public continued to be unwilling to work closely with the person in the vignette, socialize with the person, or have the person marry into their family. The majority also said that the character with schizophrenia or alcohol dependence would likely be violent toward others. In both survey years and across all conditions, holding a neurobiological conception of mental illness tended to increase the odds of endorsing treatment. However, having a biological understanding of the illness was either unrelated to stigma or increased its likelihood. And the difference in the predicted probability of stigma between respondents who held a neurobiological conception and those who didn't was larger in 2006 than in 1996. For the depression vignette, a biological attribution increased the predicted probability of perceived dangerousness to self by 20 points in 1996 and by 35 points in 2006. Pescosolito and colleagues note that the vignettes in the survey did not include persons who had been successfully treated for mental illness. Mitigation of symptoms might reduce stigmatizing responses. The authors add a clinical note. They advise clinicians to be aware that focusing on genetics or brain dysfunction to reduce feelings of blame may have an unintended effect. It could increase the patient's and family's feelings of hopelessness and permanence. Considering the neurobiology of mental illness leads us right into our next article, A Study of Brain Functioning in Postpartum Depression by Edie Moses-Kolko and colleagues. The outcomes of treatment are often disappointing, so a better understanding of the mechanisms in postpartum depression could be valuable. Hormonal dysregulation appears to be important, but little is known about neural factors. Imaging studies in non-postpartum depression and in normal motherhood point to a neural circuitry that supports attunement to the infant's emotional state. The circuit includes the amygdala and brain regions involved in social cognition. Previous findings about the amygdala have been inconsistent. Patients with non-postpartum depression have shown elevated amygdala activity in response to fearful and sad faces, whereas depressed mothers have had reduced amygdala activity in response to negatively valenced words. So the amygdala was a focus in the present study, along with the dorsomedial prefrontal cortex, where differences in face-related activity were expected. Functional MRI was performed while depressed and healthy mothers performed a task that included pictures of faces showing anger or fear. All of the women in the study had delivered a healthy term infant in the preceding 12 weeks and were medication-free. They included 14 depressed mothers and 16 healthy mothers. They were presented with a target stimulus and told to select one of two images that would match the target. Trials of the face matching were interleaved with a sensory motor control task. The faces portrayed fear and anger, and the control task showed simple geometric shapes. There were no significant group differences in accuracy or reaction time. There was no main effect of group on neural activity in the regions of interest, but in response to the faces, the healthy mothers showed significantly more activity than the depressed mothers in the left dorsomedial prefrontal cortex. The dorsomedial prefrontal cortex is involved in voluntary and automatic control and reappraisal of emotional responses. It's also part of the social cognition network that allows an individual to recognize and consider the emotional experiences, values, and goals of others. So lower activity in this region in response to negative faces in depressed mothers might represent diminished awareness of the emotions of others, as well as less empathetic responses. These characteristics have been reported in individuals with postpartum and non-postpartum depression. Within the group of depressed women, there were associations between clinical characteristics and activity in the amygdala. Those who scored lower on a scale of hostility toward the infant had greater activity in the right amygdala. Depressed mothers with more severe depressive and anxiety symptoms had lower activity in the left amygdala. Because the left amygdala was related to depression severity and was activated in response to faces more than to shapes across all subjects, it was used as the seed region in analyses of functional connectivity. In the healthy mothers, the left dorsomedial prefrontal cortex was the only area of interest in which significant connectivity to the left amygdala was found. It had a dominant influence on the left amygdala in response to faces. In contrast, the depressed mothers showed no connectivity between the left amygdala and any other region of interest. The editorial by Ellen Liebenluft and Kimberly Yonkers highlights the importance of maternal-infant interactions and how they're affected in postpartum depression. The need for pathophysiological studies to guide development of new treatments is really pressing because the illness affects not only the woman, but also her newborn and other members of the family. A hallmark of depression is greater focus on the self, and research indicates that it may be mediated by the dorsomedial prefrontal cortex. This region is activated when subjects are asked to perform, quote, theory of mind or mentalizing tasks. These require subjects to focus not on their own thoughts, but on the thoughts, beliefs, or feelings of other individuals. As any parent who has tried to calm a fussy baby can verify, parenting a pre-verbal child may be the ultimate challenge to one's mentalizing ability. An elegant interplay occurs within healthy infant and mother dyads as they communicate by mutual gaze, vocalization, and nonverbal expressions of affect. Observational studies show that on average, depressed mothers show less positive affect toward their child than non-depressed mothers. They also engage with their child less often and are less sensitive to the child's cues. These parenting difficulties are related to subsequent deficits in the infant's social engagement and emotional regulation. An important question is whether a depressed mother's difficulties in interacting with her infant are mediated by dysfunction of the dorsomedial prefrontal cortex. To address this question, future studies could evaluate depressed and comparison mothers' neural responses to verbal or auditory cues from their own infant, compared to their responses to other infants and to non-infant stimuli. This neural activity could then be correlated with observational measures of the mother's interactions with her infant. A few functional MRI studies in healthy mothers have tested neural responses to the infant's cues, but the results haven't been consistent. However, activation in Brodmann's area 32, the dorsomedial prefrontal cortex, has been noted when healthy mothers hear their infant cry or when they watch a video of their infant crying after being separated from its mother. Ultimately, this research will have the greatest impact if it leads to new treatments. Both the mother's depressive symptoms and adverse mother-infant interactions should be considered important treatment targets. We don't know whether successfully treating a mother's depression will necessarily improve her parenting interactions, but preliminary evidence suggests it may not. Several trials of interpersonal psychotherapy have evaluated the impact of treatment on parenting, but outcomes were measured with self-report scales, which may be less reliable than observational measures. The most effective strategies for treatment development in postpartum depression would combine expertise in clinical trials, observational studies of mother-infant interactions, and neuroimaging. The combination of functional MRI and carefully designed behavioral paradigms could be used to identify the neural mechanisms that compromise a depressed mother's ability to respond to her baby. For example, investigators could test whether infant-related stimuli are less emotionally salient for depressed mothers than for non-depressed mothers, with emotional salience measured by reaction time and the degree to which stimuli engage bottom-up attentional circuitry. This would include the amygdala and the ventral prefrontal cortex. Also, given the anhedonia of major depression, one could test whether women with postpartum depression are less likely than unaffected women to find interactions with their infants as rewarding based on self-report, behavioral measures, and striatal activation. The degree to which attentional versus reward deficits contribute to parenting difficulties can inform the development of new psychotherapeutic approaches. Now we'll turn to 3 articles on the genetics of autism spectrum disorders. We'll start with the study by John Constantino and colleagues, Sibling Recurrence and the Genetic Epidemiology of Autism. Patterns of sibling recurrence can help determine the mechanisms of inheritance for any genetically influenced condition. The siblings of probands with autistic disorder have a 22-fold relative risk of developing the disorder. However, recent discoveries suggest that there are multiple genetic mechanisms, each with its own pattern of intergenerational transmission. Also, autistic symptoms have a wide continuous distribution in the general population and in clinical cases, and in studies of non-familial autism, families appear to contain discrete populations of affected and unaffected children whose severity distributions partially overlap. Constantino and colleagues analyzed data from a large registry of families with an autistic child, in which both the affected child and other children had been evaluated. There were 2 main objectives: to estimate the risk of sibling recurrence and to explore the distributions of subclinical autistic traits in families with and without other affected children. The large sample also allowed the authors to examine whether an aggregation of language delays in siblings not diagnosed with autism might constitute another type of recurrence. One of the parents in each family provided quantitative information on autistic symptoms in their children between the ages of 4 and 18. They did so by completing the social responsiveness scale for each child. More than 1,200 families were included. Each parent also indicated whether each child was or was not affected by an autism spectrum disorder diagnosed by a clinician or educational professional. 11% of the families had more than one affected child. In addition, among the children classified as unaffected, 20% were reported to have a history of a diagnosed language delay or speech problem. This rate is at least double the reported prevalence in the general population. The finding prompted an examination to identify children with delayed language who also had language impairment. Each child's history of communicative development was retrievable because the parent also had completed the social communication questionnaire for each child. A key item set corresponds to symptoms in the communication criteria for the DSM-IV diagnosis of autistic disorder. It ascertains whether a child has autistic qualities of speech, including odd or repetitive phrases, socially inappropriate questions, pronoun reversal, or invented words. Positive endorsement of any of these characteristics was significantly more common in the unaffected children with a history of language delay. It was also associated with a significantly higher level of subclinical autistic social impairment in the unaffected children. More than half of the children with a history of language delay also had one of the characteristics of autistic speech. When the children with this combination were included in the affected group, the percentage of families with multiple cases of autism rose from 11 to 22%. Families with these children were considered as a separate group in the analyses. The most striking finding was an absence of quantitative autistic traits in the unaffected siblings in families with just one case of autism spectrum disorder. On the other hand, there was a relative aggregation of autistic traits in the unaffected siblings in families with multiple cases. There was an intermediate distribution in families with unaffected siblings with a history of language delay plus autistic speech. The disparate manifestations of sibling recurrence may reflect differential mechanisms of genetic transmission of autism. These mechanisms include rare recessive or de novo mutations, inherited mutations that may be expressed in various ways, and common susceptibility alleles or rare variants of minor effect. Beate Sampoursan and colleagues also examined the relationship between genetic risk and subthreshold autistic traits. Their aim was to look for an association between a high-risk autism locus on 5p14 and social communication spectrum phenotypes in the general population. The single nucleotide polymorphism, or SNP, that they examined has the strongest evidence for a link to autism spectrum disorder so far, and it resides between two genes that encode neuronal cell adhesion molecules. The population sample was determined as part of the Avon longitudinal study of parents and children. All pregnant women in the Bristol, England area with expected delivery dates in 1991 and 1992 were approached for participation in the study. In 2009, genotyping was available for more than 7,000 children. Between ages 3 and 12, standardized measures of language, communication, verbal intelligence, social interaction, and behavioral adjustment were completed. Most of the data were reported by the mother. The relationship of these ratings to the high-risk SNP were examined. The major T allele is the one conferring risk for autism spectrum disorder. The strongest associations were observed for the traits of stereotyped conversation and pragmatic communication skills. A higher load of the risk allele was related to more communication deficits. Severe problems with pragmatic aspects of communication appear to be universal in autism spectrum disorder. They're usually ascribed to an impaired theory of mind, that is, an impaired understanding of other people's mental states. There was also an association between the high-risk allele and a phenotypic spectrum of traits. The evidence for this joint phenotype was stronger than for any single trait. Communication, cognition, and social interaction appeared to play a major role in this association, such that less functionality and more problems were associated with the higher frequency of the risk allele. Paul Lichtenstein and colleagues approached phenotypes from another perspective. They examined the genetics of autism spectrum disorders and related neuropsychiatric disorders in childhood. Autism spectrum disorders are considered to be among the most heritable mental disorders, but this belief is based on surprisingly few data from small clinical studies. In addition, childhood neuropsychiatric conditions have a high degree of overlap. The authors conducted a population-based twin study to calculate heritability estimates for several disorders and to investigate whether genetic effects are responsible for the overlap among them. The Swedish Twin Registry was used to identify all Swedish 9 and 12-year-old twins. The parents were contacted for telephone interviews. The response rate was 80%, and for most of the twins, it was the mother who was interviewed. Nearly 17,000 twins were evaluated. Neuropsychiatric problems in each twin were identified by using an inventory of symptoms of autism, tics, attention deficit hyperactivity disorder, and other related conditions. It's administered to the parent and has been validated for use by laypersons over the telephone. The symptom ratings were used to assign diagnoses of autism spectrum disorders, ADHD, developmental coordination disorder, and tic disorder. Quantitative genetic analyses were used to estimate the relative importance of hereditary and environmental factors for variation in liability to the diagnosis. Phenotypic variance was divided into one component due to inherited genetic factors, another component due to environmental factors common to both members of the twin pair, and a third component due to environmental factors unique to each twin. Just under 1% of the twins met the criteria for autism spectrum disorders. The concordance rate in boys was 0.47 for monozygotic twins and 0.14 for dizygotic twins. Among girls, there was only one concordant twin pair. Monozygotic twins also had a higher concordance rates than dizygotic twins for ADHD, developmental coordination disorder, and tic disorder. Genetic effects accounted for 80% of the variation in liability for autism spectrum disorders. There was no indication of shared environmental effects. The remaining variation in liability was due to non-shared environmental effects. Genetic effects were also high and significant for other disorders. The heritability estimate for ADHD was 79%. For developmental coordination disorder, it was 70%, and for tic disorder, it was 56%. Half of the children with an autism spectrum disorder also met the criteria for ADHD. In monozygotic pairs, the probability of ADHD in the co-twin of a twin with autism was 44%, but it was only 15% for a dizygotic co-twin. Results from formal model-fitting analyses suggested that about 3/4 of the genetic variance in autism was shared with ADHD. The effects across disorders were also higher in monozygotic than dizygotic twins for most other comorbidities. The findings support the concept of a general genetic susceptibility for developmental mental health problems, rather than the notion that specific genes cause specific disorders. Now we'll conclude with the randomized controlled trial by Patricia Arian of problem-solving therapy and supportive therapy in older adults with major depression and executive dysfunction. Executive dysfunction is common in late-life depression and predicts slow, poor, and unstable response to antidepressant drugs. Problem-solving therapy has been shown to be effective in older adults with depressive syndromes, and it's a rational approach to those with executive dysfunction because it has the potential to mitigate their behavioral disability. The intervention used in the trial has a sequenced approach to teaching problem-solving. Participants learn how to target problems, arrive at action plans, and implement those plans. Treatment lasts 12 weeks, and the model is taught over the first 5 weeks. Subsequent sessions are dedicated to refining problem-solving skills. This intervention was compared with supportive therapy. These therapists did not engage in any therapeutic strategy other than active listening and offering support that focused on the patient's problems and concerns. This treatment also lasted 12 weeks. The participants were age 60 or older and were recruited through radio and newspaper advertisements and contact with providers. More than 200 persons were included in the study and randomly assigned to treatment. To be eligible, they had to meet the DSM-IV criteria for major depression and have a score above 20 on the Hamilton Depression Rating Scale, a score above 24 on the Mini-Mental State Examination, a score below 3 on the Initiation and Perseveration Subscale of the Mattis Dementia Rating Scale, and a score below 25 on the Stroop Word Color Test. These measures of executive function were selected because they can detect executive dysfunction in late-life depression and because poor scores are associated with poor response to antidepressant medication. The rates of attrition were low and were similar in the two groups. Both treatments were associated with reduction of Hamilton depression scores, and the decreases were similar during the first 6 weeks of the trial. However, at weeks 9 and 12, the group that received problem-solving therapy had significantly greater decreases in depression scores. Response to treatment was defined as a reduction of at least 50% in the Hamilton Depression Score. At the end of treatment, the response rate was 57% for problem-solving therapy and 34% for supportive therapy. A similar difference was seen in the rate of remission, which was defined as a Hamilton score below 10 for 2 consecutive weeks. The remission rate was 46% for problem-solving therapy and 28% for supportive therapy. The differences in response and remission also emerged only at week 9. Most patients require approximately 6 sessions to learn the principles of problem solving. So the advantage of problem-solving therapy may emerge only as the new skills are developed. This wraps up our audio highlights of the November issue of the American Journal of Psychiatry. Please visit our website, ajp.psychiatryonline.org, for the complete versions of these and other articles, including author affiliations and financial disclosures. We also welcome comments about our audio digest. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio digest will highlight deep brain stimulation in a case of refractory depression, early family intervention for childhood anxiety, personalized treatment selection for depression, change in the proportion of patients receiving psychotherapy, and adult outcomes for children verbally abused by peers. We hope you'll join us. Thank you.